Okay, we're live.
Good evening, everybody. And this is our last clinical meeting of 2020. The Bose Institute Joint and Bone Care Hospital, Kolkata. And we have our expert panel today. Dr. Devjyoti Bose sir is there. Dr. Golok Bihari Maji sir is there. MM Rai sir will join after a while. And Giri sir will also join after a while. Thank you to expert panel for joining here. And over to you, Chinmay Desai, President sir, for a few words.
So, good evening, everybody, and welcome you all to join this clinical meeting after a short pause. We didn't have anything in November, so it is by the age. So experts are all senior and past presidents and galaxy of past presidents. Also, I can see the Amitabh very expert in academic field, and we think we will have lots of discussions because the institute is very famous for many cases. So, with these few words, I over the program to the presenters. Thank you all.
Dr. Partho Sarthi Sarkar, our secretary, honorary secretary of WB, has also joined. Partho, few words from your side.
Yes, thank you, sir. Thank you, Rajiv. It is actually this venue is new for us, but the recent past year they have done lots of orthopedic surgery, and we are there at least 30 orthopedicians who are regularly doing their surgery, different type of surgeries. So we have included this year this JBCA hospital, joint and bone care hospital, with the we have a orthopedician in this hospital as a director, Dr. Jaideep Banerjee Chaudhary. He is a very actually the institution is very well organized in respect of this orthopedic operation and orthopedics management. So we have included this, but due to this COVID pandemic, we have approached different regular government and other institutions, but due to the paucity of this faculty, they have unable to organize this kind of e-clinical meeting. But this will be resolved soon, because from the next year onwards, from the January, we are organizing more than one clinical meeting, because we have a proposal of at least 3 clinical meetings for the January. So it is we are very much fortunate that everyone is interested to doing this clinical meeting, and it is only the encourage of our seniors, especially the Golok Bihari sir or Devjyoti Bose sir, or our president, especially, he has unconditionally supported us in every academic activity. And also our president elect Kanchan Bhattacharya sir, and our vice president Aniruddha Sengupta sir, and also our scientific team Rajiv Raman and Sabyasachi Chhatra, and a man who is working behind the scene is the Arnav Kormukar. And he is doing this silently in each and every meeting. We have done at least 50 meetings, and I think it is the second highest or the third highest in respect of this all IOA, because only one state, that is Gujarat, they have performed more than 70 meetings. So this is only because of Arnav and the webinar committee, and of course our scientific team. And I must say that all the JBC orthopedic surgeon, our JBC itself, Dr. Kiran Mukhopadhyay sir, and Dr. Tanmoy Karmokar, and also Subhadeep, and there are lots of surgeons who are very much ready with their case, but due to the short notice of this meeting, they are unable to join. And especially, I welcome our guest expert panel, Dr. Devjyoti Bose sir, Dr. H.P. Giri sir, Dr. MM Rai sir, and Dr. Golok Bihari Maji sir. With this, I conclude my remark, and over to Rajiv. Thank you all.
Thank you, Partho, for your kind words. I think we will start our presentation. We can start with Tanmay. Tanmay has joined. Tanmay, you can start your case presentation. So case presentation is 5 minutes. After that, we will have question from expert panel. Amitabh, you can also join in asking question. All right.
Okay. Can I share my screen?
Yeah, please. Welcome, Joydipta.
Good evening, everyone. Merry Christmas and early Happy New Year to every one of my seniors. I'll be presenting today a very peculiar complication of arthroplasty surgery. So the history is a 63-year-old male patient presented to us with a 2-month-old intracapsular fracture neck femur. Within his comorbidity, he is type 2 diabetic for last 2 years with HbA1c less than 7 with relatively good control of blood sugar. His urine RE was normal and other infective parameters were also normal. So this is the presenting X-ray. So what are the treatment options to us? Can we discuss, Rajiv Da? Or is
No,
it
as you present, I think question will be asked by expert panel. Yeah.
okay? So I went for total hip replacement as the patient was wanting immediate mobility. I went for a hybrid total hip replacement, which was done by modified hard hinge approach. Early mobilization was the motto. This is the post-op X-ray. On the uncemented part, the acetabulum was done uncemented, and the femur was done cemented. So this is the 2 months follow-up. We can see the lateral part of the cement mantle. There is some loosening, and there is some bending of the stem. So this is the 4-month follow-up. There is gross bending of the femoral stem with loosening of the lateral cement mantle. This is the lateral view. Distal cement mantle is very good. So I planned for the revision of the stem to restore the hip biomechanics. The infective markers were also normal at that present moment of time. Modified hard hinge approach was chosen. Hip dislocated. The stem was tapped out as it was double tapered stem. So removal of the stem wasn't too difficult. Extended trochanteric osteotomy was done from the beginning to remove all of the cement mantle. So this is how we did the extended trochanteric osteotomy. All cement mantle, including the centralizer and restrictor, was taken out. Canal was prepared for uncemented distal fitting stem. ETO was closed provisionally with wires. After that, trial was inserted and final implantation done with solution stem. Control cables were applied to strengthen the ETO fixation. So this is the clinical picture of the total cement mantle which was taken out. This is the distal fitting uncemented stem. And this is the post-operative X-ray. Very sorry that I cannot present any clinical pictures of the patient. The ETO looks fine, looks united. It is 2 months after the revision surgery.
Stop sharing, yes. Okay. Yeah,
My
question, please.
question, yes, my question is to you. This is a 2 months old neck femur fracture.
Yeah.
In a 62-year man with a controlled diabetes. So the treatment options were many. Why did you prefer this THR over the valgus osteotomy?
One factor was that patient himself wanted early mobilization, and I am also comfortable doing THRs along with if I did the valgus osteotomy, then the patient would have been non-mobilized at least for 2 months or 3 months more.
No.
I preferred the.
Does all panel agree to it that after valgus-ostomy, you need 2 months bed rest?
At least not bed rest, non-weight bearing, that is mandatory for at least 2 months.
Okay.
One question from me.
Yes, sir.
Yes, sir.
So, what, in your opinion, was the cause for bending or failure of this implant?
That I also want to know from the seniors.
What you assess? Your assessment. First.
According to my assessment, the stem was too thin for that patient, maybe, and there might be some cement loosening also. These might be the causes.
Was it a custom made or is it from some other company made? From reputed company?
Company made. This is the Exeter type of stem prepared by Biorad.
Do you think there is some varus implantation post-op X-ray? Have you
Yes.
seen the X-ray? There was a varus position of the THR, as I think. Probably that's the cause of failure.
I don't think that, sir.
The stem
Can
was
I-
centralized.
Can
Yeah,
I say
Amitabh,
something?
yes,
Yeah,
last
it-
question. Yeah.
Or no, I think this case is managed very well. But if you go back, as you said, the primary total hip stem was thin, absolutely thin. If you can go back, and what other point I wanted to see, did you notice the lateral, the calcar cortex part? I think there was some deficit in the. If you can go back to the postoperative X-ray, if you can see the calcar part or the I think there was some deficit in the calcar part. Arnab, did you have you noticed that?
Sir, I'm just opening the.
One is definitely, as you said, the stem part was thin.
If I may just make one point, that the thinness or the thickness of the stem won't lead to this kind of elastic deformity.
Yes,
Yeah.
yes.
It's more of problem with the implant.
Yes.
Yes. Agreed.
There is no
JVC.
balance of the implant. The stem is absolutely centralized.
Yes.
Yes, it was not virus. I think gradually the cement mentally start breaking up, and that was the cause of loosening that lead to failure of fatigue fracture of the stem. So, Jaydeep, the last comment from your side here.
The stem didn't fracture, Rajiv. It was just bent.
Bend,
Yeah.
like this.
Stem didn't fracture. I think this was problem with the strength of the
Implant.
Implant.
So,
The
last
implant
question.
itself.
Last question, Tanmay. Why hybrid? Why don't you prefer uncemented?
I can conclude it was not the failure of surgery. It's a failure of the implant itself.
Yes.
To your question, the answer was financial, nothing else.
All right. Nice presentation. I think I would like to ask all the expert panel to evaluate and put marking and send it to me or Sabyasachi Satra, please. Devjyoti sir, Gulak Bihari Maji
Sure.
sir.
Sure.
So next case I think will be by Jaydeep Banerjee Chaudhary. He is director of Joint and Bone Care Hospital, Kolkata. Jaydeep, over to you.
Okay, I'll just give me 1 minute. I'll share my slide. Am I visible?
Yes. Make it
Full screen.
full screen. Yeah.
Able to
Jaydeep,
make it full screen.
you start play. The play option is there. Play. Upside you have the play option. Yes, click it. Yes. Now it's okay.
It's okay.
Mhm.
It's I think this is a sequel of the first case, as Tanmay showed, that it was a failure on the hip side, in a THR side. I would show you one case where this was a failure on the TKR side. The history was that this is a 55-year-old lady who had bilateral advanced grade 4 osteoarthritis of the knees, and she was advised a total knee replacement and underwent a bilateral total knee replacement in August of 2019. though the primary surgeon wasn't me. She had an uneventful post-operative phase and mobilized quite well according to her schedule and got better. A standard prosthesis was used and which was fixed bearing. She went on to do well till April of 2020, which is about, I would say, about 7 months. In April, she felt a click in her knee. It wasn't a fall, trauma, twisting injury, nothing of that sort. One fine morning, she just felt a click in the knee. Since then, she had some pain. It wasn't severe, but there was some pain in the knee, and it was not associated with any swelling of the knee. Her gait changed, and she felt very unstable in her knees, the left knee. Both the knees, the right was doing absolutely well, while she became very unstable with her left knee. And she complained that while walking or weight bearing, the knee was going backwards. On examination, she had a good GC and was medically fit. She was only 55. She had, on examination, she had a grade 1 synovitis in the left knee. There wasn't any local warmth or rise in temperature, or there wasn't any pain associated with the movements. Movement wise, her knee was going into hyperextension, though in full extension as well as in 30 degrees and 60 degrees of flexion, her MCL and LCL were, both of them were stable. There was no neurovascular deficit, and she was by that time mobile only with a walker, but she had the same problem of the knee going backwards. That was her complaint. This was an X-ray which was taken in the OPD. The lateral view shows a standard sort of TKR done, cruciate sacrificing, with the implants well fixed, while the AP view showed that there was quite a degree of lateral subluxation of the knee. There was this small fragment of bone, which I initially thought that could be from LCL avulsion, from the femoral component. But this was the X-ray. I couldn't make, it's difficult to make out from this what her problem was. So we proceeded on to investigate her further. Her infection screen came back negative. I did a CT scan, which showed no loosening of the components. Apart from this, nothing else could be elicited. So we proceeded, I spoke to my radiologist, and we went for an MRI scan just to see that whether anything could be commented about her ligament status. On the MRI scan, the ligaments were okay. And he called up to say that there were some echogenic particles in the knee and a large one in the suprapatellar area. And his suspicion was that it may be that these fragments could be from the insert, which was there. That also, if we went back and corroborated with the X-rays, that because the femoral and tibial components were so close to each other, that it may be a insert fracture. So the working diagnosis was that it was a case of insert breakage, and we had to go ahead and plan a revision surgery. I was not comfortable about the implant which was put in. So I counseled the patient party, and I counseled them that I may have to do a full revision, even if I see that the femoral and the tibial components are well fixed. So on examination table, on OT table, she had, you can see the picture on the left that it had good range of flexion, while in extension, you can see the degree of hyperextension. It's almost about 20-25 degrees of hyperextension in that knee. Varus valgus was stable, acceptable. And so we now proceeded with opening up the knee and seeing what's the problem. On opening, if you see closer, what we found is that the insert, the peg was broken. As you can see on the picture on the right, I held it with an artery forceps, and the peg was lying there, but it was fractured, broken. We removed both the components. We removed all bits of cement, whatever we could. And then we had to proceed with a full-fledged revision. On the tibial side, we had to use 2 half wedges because I always prefer leaving the knee joint at the proper joint line. So had to lift the tibia up, tibial joint line up. So use the 2 half wedges. And on the femoral side, we had to, in the posterior condyle, we had to use a 5 millimeters block, and distal femur to build it up. Mainly on the lateral side, we used a 10 millimeters block. At the end of the surgery, you can see that the hyperextension has been corrected, and the flexion, we have restored our flexion to what it was pre-op. The knee was fully stable all through the range of movement, and the patella was tracking normally. These were the post-op x-rays. As you can see that the joint line now has been restored to the normal position. We got away with using a 10 millimeter insert, and the alignment is good, and the extenders both on the femoral and tibial sides were well fitting. So this is now her clinical pictures. She has got movement of up to over 110 degrees plus. And you can see that the picture on the right, that she has got no FFD in her knee. Now, if we have to go back and discuss about this case, that primarily it's very unusual for post-fracture within 7 months of surgery. This is very unusual. I've never come across this, and I've spoken to a few of my friends. There's no in the literature as well that so early it's not reviewed in the literature. On closer look of the knee when we explored it, it seemed that the previous surgeon had left the knee slightly loose. Probably I would have used a larger insert to get away with it. Whatever implant, that this is a learning point, that whatever implant we use, make sure that the revision implant are also available of all sizes. I'm making this point deliberately because that with this post-fracture and a well-fixed femoral and tibial components, I could have got away easily with just changing the insert. But the company which had provided the primary implant, they said they didn't have that size insert or revision set with them. So we should always aim for a normal joint line, and we should not aim or settle for a higher or lower joint line, or else we'll have different problems, but patellar tracking and everything. There's another point that both these, I don't want to name any companies or any implants, but both these implants which you saw, the hip as well as the knee, are from same company, and we have burnt our fingers and promise not to use it ever at all. Thank you very much. Happy New Year to all of you. Thank you.
Thank you, Jayadipta. The case is open for discussion. Anuradha, any question? I have stopped sharing your screen, Jayadipta.
Huh?
Do you want to show something? No.
No. It's any questions?
No question. Basically, we have learned something that you guided us. It should, from a good company, it should have a backup. Those things should be, those things we learned. So nothing is question about it. Good surgery, revision was very good. And this is a good learning that it is, we have learned that during knee surgery, don't take it very lightly. Take all the implants, all the.
The only thing is that what put me off was that this components from this primary company, they just turned around and said that they don't have a revision set, and which was very surprising that they can give me the revision set, but they won't have implants available. So it's very risky to use implants from a company who cannot provide you with backup.
That's very important.
Tanmay, any question from your side? I think you were part of operating team. I saw your picture
The
there.
operating team, so I know everything of that part.
Nice demonstration, Jadipta. Excellent. So, Jadipta, when you think about using this constant prosthesis with a long stem, suppose the only constant prosthesis, or how do you decide what should be the length of the stem in such type of cases?
What should be the
Length of the stem, length of the stem.
recent trend is that you should use a short fat stem. Because the problem with long thin stem is long stems are that gives rise to stress riser and you can have a fracture distally. So the trend is that you should use the short fat stem and it should be properly cemented. So I usually go for that's my aim, but it again would depend on the reaming what I get. But usually for the tibial side or the femoral side, these reamings are done with hand. So you get a feel that when it starts getting sort of hitting the cortex. So you shouldn't go beyond that. And lengthwise, aim for the shorter ones, if necessary, just to stabilize it as much as you want to go up. But the principle is short and fat.
Stem should be scratch fit.
Yes.
Thank you, Jadipta. I think the next case presentation is from Dr. Kiran Kumar Mukhopadhyay. He is a spine surgeon. Kiranda, please start sharing your screen.
Good evening, my seniors and my friends, colleagues. So today I'm going to present a case of scoliosis treated through combined approach, anterior followed by posterior. Most of the spine surgeons nowadays they prefer only posterior approach for all types of spine surgery. But my purpose of presenting this case is that in selective cases, anterior surgery is very useful. Actually, it may be very essential for the benefit of the patients. So, while treating AIS scoliosis, so if the patient is an elder age, in a not present in younger age, then it become usually very stiff, and the curve that do not reduce much on lateral bending, you can see in the picture, is more troublesome and difficult to treat surgically. And also, these type of curves in older age group, they require a longer fusion. So there are literature supports also, combined anterior posterior instrumentation is required for severe and rigid idiopathic scoliosis. But still, majority, almost all of the spine surgeons nowadays, they try to go from posteriorly and they don't advocate anterior surgery, though there are literature supports. So this is a patient, is a 26 years old, presented first time with this type of cosmetic deformity. It's a Lincoln 5C type of curve. The thoracolumbar curve or lumbar curve, the thoracolumbar curve is the major curve and structural, and the thoracic curve is non-structural compensatory. This is a 62-degree curve. And you can see this is almost unaltered on bending. But if this patient was presented at the age of 11, 12, 13, 14, so these on the bending curve, the curve could have been reduced to near normal. So I first went anteriorly in a thorac-abdomen approach. You can see these points. These are the disc spaces. So anteriorly, we just releases the disc. It's better to do with a laparoscopy or thoracoscopic surgery, but we don't have the facility, and I don't have also training on that. I tried with my, I talked with my general surgery friends, but they are also told that they don't have expertise on that. So only anteriorly, we what we do only just the release of the disc, and then the disc spaces are filled with artificial bone gas, the used, and also the artificial bone gas we can use, and then we just close the spaces, and then we turn over the patient, close over a chest vein, and they turn the patient prone, and from the posterior aspect, we do a usual posterior correction. This is the mark. This is the thoracoabdominal approach, and this is this posterior approach. So rigid curves are very difficult to correct posteriorly alone, and often undercorrected, and there are higher chances of neuro complications, and it requires a long fusion. But anterior release is correction. The rotation is very simple and very easy if we do anterior correction, and it always requires a short segment fusion and a higher correction. Almost full correction can be achieved if we do a anterior release first. So in this case, if I would have done it posteriorly, then I have to fix from T4 to L4. But in this case, I have used a very shorter fusion from D9 to L3, and the curve was covered. The curve was corrected. It was earlier it was 62 degree, and it was corrected to 18 degree only, almost near normal. And this is the cosmetic correction. It's I think cosmetically is absolutely normal, and the patient is very happy. Is walking very steadily and cosmetically very good. And this is just another example. This is another case done by me. Is a 54-degree angle anteriorly. Both this is a combined approach, first anterior followed by posterior, and a very short segment fusion, and it is almost full correction. And this is a cosmetic correction, and this is the same type of incision, and the correction is near full. Thank you very much.
Thank you, Kiranda, for excellent case demonstration. The case is open for discussion. We have lots of spine surgeon here.
Hello.
Subhadeep, any question from your side? Yes.
No, sir, both the cases are superb because the purpose of anterior surgery is basically two, is the release and short segment. And both the principle and purpose are well served in both these cases. So there is good release, and the release spaces has been filled up with autogenous bone graft. So 360-degree fusion is also there. At the same time, the construct is much shorter in comparison with what's needed in posterior surgery alone. So therefore, we can save more spaces, mainly the lumbar discs, which are useful for our movement. So both the principles and purposes has been well served.
Actually, Shubhadeep is also from our institution, so he has seen many anterior surgery in our institution. But I will ask Shubhadeep. Shubhadeep is going is a very aspiring spine surgeon. Is doing very well, and is going everywhere to attend the conferences. But what I started with that point that most of the spine surgeons they never want to go anteriorly.
Yes, sir.
So, but my purpose of presenting this case is that I also do majority cases through posterior approach only.
Yes.
But my purpose of presenting the case is in selective cases this is very useful. So every spine surgeon should know the anterior approach also. That's my purpose of presenting this case.
Just for understanding, what is the approach anteriorly? How do you go there?
On anterior approach?
Yeah.
Yes, approach.
Anterior approach, either I go transthoracic or if I require a lower level also, then I do a thoracoabdominal approach.
That's for scoliosis. What approach you do? Because the curve is from dorsum to lumbar.
In both of the cases, I went thoracoabdominal.
Thoracoabdominal.
Sir, in
I
scoliosis,
have more than 150 anterior surgery, thoracic, transthoracic, or thoracoabdominal. And for first 4 to 5 cases, I took assistance of my senior Uttam Mukherjee, cardiothoracic surgeon. But after that, I usually do it alone.
Number of bloods are more required for this type
Anterior surgery
and posterior surgery.
anterior surgery is relatively a bloodless surgery.
Yes.
A very minimum blood loss. But posterior surgery nowadays also bloodless surgery if you have a good anesthetist and good operation room setup. It's a posterior surgery is also nowadays we don't require blood transfusion in majority of the cases. Kashmuddin?
Yes, sir.
In majority of the cases, if you have a very good anesthetist and a very good operating room, we don't require blood transfusion.
Sir, anterior surgery for release of scoliotic, we usually approach from the convex side, and it is a bit easier because the spine is more nearer to the incision.
Always convex side.
Always
Always
convex side. And
Kiran, do you need neurological monitoring to correct these?
yes,
actually, the facility is not available, so I never used neurometer. I used lately I used 3 or 4 cases. I have to hire that on 10,000 rupees per OT. But only in 4 to 5 cases. But in one case, I can remember in one scoliosis it was misguiding rather, because you need a very good interpreter, very good competent interpreter. Otherwise, you will be in the middle of the operation, you will be puzzled. The interpreter must be very good.
Kiran?
Yes.
শুনতে পাচ্ছ?
Yes, sir. বলুন, sir.
আচ্ছা। Why the spine surgeons do not take the anterior approach? The reason is because the orthopedic surgeons are rarely trained abdominal or thoracic exposure, rarely. So naturally they won't opt for the anterior exposure. Because yes, you are correct. Blood is relatively less blood loss is in the anterior approach, whether it's thoracic level or in the lumbar region, retroperitoneal. It is easier, and because you are directly approaching, in some of the cases, particularly tuberculosis, tumor, you are directly approaching the disease. The management will be relatively better. But the reason is why they avoid, because they don't have the training, and sometimes they have to, particularly in the corporate sector, they have to hire the other surgeon, general surgeon. It will be more expensive. I have heard that you will know better that in USA there are a group of surgeons who are called the exposure surgeon. They work with the spine surgeon only to expose anteriorly to expose the spine, blunt. But in our country, such facility is not there, and why posterior and definitely in some of the cases, as you have, so in these cases, some of the cases management by the posterior approach is relatively difficult. Sometimes it is more extensive. They may show the reason, they may support in favor and purpose. But the only thing is that they are.
I have seen one lumbar disc replacement in UK. The spine surgeon, he just cuted the disc and put the lumbar artificial disc. Otherwise, everything was done by a replacement surgeon. Exposure surgeon. A group of surgeons came, they opened the abdomen, they did everything, they exposed the disc, the spine surgeon, he just put the disc and put the artificial disc there, and the closure was also done by that team.
So now we will thank you, Kiranda. Excellent case demonstration presentation, and I think Subhadeep is also presenting a spine case. So now we can have a scopy case in between 2 spine cases. Arta, you can present your sports case. Then we will.
Okay, sure.
Yeah. Rick has not joined yet, I think.
Okay, so I'll show one case of recurrent patellar dislocation in adult. It has been treated by MPFL reconstruction, relatively new method. I thought and I tried to do, and by tibial tubercle osteotomy. So why actually I thought of this, and what led to me think about differently is that sometimes when we are actually planning for MPFL reconstruction, we need to understand that MPFL has got a broader insertion on the patellar side. So we need to recreate that. If we are going for any ligament reconstruction, we always should think about recreating both the attachment sites in the bones. So, but if you drill more holes on the patella or something like that, there is a high chance of iatrogenic patella fracture. So various methods of MPFL reconstruction in the patella has been devised, and many people actually do different types of methods. So to prevent iatrogenic patella fracture, that was our main motto. But we want to recreate the fan-shaped insertion of the MPFL with the patella. Strong, robust fixation in the patella, because in adults you need to put them on early rehab. Otherwise, they will turn up in stiffness. And finally, we tried to do it in a biological manner so that we don't want to put any hardware within the patella. That can again increase the chances of iatrogenic patella fracture later on. And to my thoughts and utter surprise, I searched and I found one such paper which they have also tried to do something like the same without any device fixation in the patella. If you can understand, there are various ways to treat it with the ligament, with the graft which has been tunneled through the patella and then fixed in the femur. I'll show what I have done. So that was the thought behind this. The patient was 32-year female which presented with a left-sided recurrent patellar dislocation. We excluded any valgus deformity, any generalized ligament laxity. The apprehension was positive and the retropatellar tenderness was there. And the movement was okay, terminally restricted. So these are the videos, and I'll skip on that. So on investigation, we did all the investigation to rule out any shallow trochlear groove or any alignment issues. So we excluded that there was no alignment issues were there. Then finally, the insult-sorbity ratio and the TTTG ratio. These are the two very important factors to look upon to understand the pathology of recurrent patellar dislocation. So the insult-sorbity ratio was 1.26 on MRI. So it was more than 1.2. So that requires distalization of the tibial tubercle. And the TTTG ratio was like 21 in the CT scan. So that requires slight medialization of the tibial tuberosity. And in MRI also that shows edematous MPFL in its insertion, and that signifies the tear, which is a chronic MPFL tear. So we decided to treat this case with a combination of MPFL reconstruction with Semitic graft, obviously, and tibial tuberosity transfer, distalization, and medialization. So this was the scopy before operation. So if you can see that this is the trochlear groove which is visible, and this is the patella. Patella was high up and it was actually sitting on the lateral femoral condyle. If you can understand from this scopy that it is totally lateralized. So that was the picture op. So we first harvested the Semitic graft. That was our outline of plan of management, plan of operation. So we outlined the patella and the tibial tuberosity, and there the two incision marks are marked. One is for first harvesting the Semitic graft, another incision for the drilling in the patella. So we planned for drill in the patella, half holes in the patella, and another one is for the insertion point in the femoral distal medial femoral condyle. So first we went after having the graft, we went for the tibial tuberoscal osteotomy. So we planned our osteotomy, then we drilled hole, then we osteotomized the tibial tuberosity. Then we removed the distal part of the tibial tuberosity by the saw. If you can see that this is the lower left picture, saw is cutting the distal part of the tibial tuberosity. 2 centimeter bone was removed. Then after extension, we then fixed this tibial tuberosity flushed with the distal part of the tibia. So that actually distalizes the tibial tuberosity, and we also medialize the osteotomized tibial tuberosity. So that finishes, and we fix it with 2 screws. So that finishes the distalization and medialization of the tibial tuberosity. Then we went ahead for drilling in the patella. We give an incision on the patella side. If you can see that we give an incision on the patella side, then we drill it to parallel drill holes with bit pins, and then take the bit pins on the another side. So that's how the patellar drilling has been done. 2 bit pins has been done. Next step would be drilling with the 4.4 mm drill bit. So here you can see the 2 parallel bit pins has been drilled. Then we drill 20 mm. We drill. So in an adult, 20 mm would be a half of the patella. So our principle was to the graft should be filling the half of the patella bone. So we drill 20 mm with 4 millimeter of drill bit. Then we can see that the prepared graft, both the free ends of the prepared grafts are actually taken out through the bit pin. So now you can see that how the graft is going in within the patella. I put a suture to loop around so that we can pull the another end of the graft to the femur. So now we tie the sutures in the opposite end of the patella. So this is how it actually fixes the graft within the patellar bone. So next is the femoral entry point. We have to decide the femoral entry point. We know the Scottle's method is there. So by that, we actually decide the femoral entry point for MPFL. And if you can see from this CM view, the two tunnels, the outer big tunnels and inner small tunnels, two tunnels are visible. It's in proper location. So you can exclude that you have not damaged the patella, and there is very, very less chance of iatrogenic patellar fracture there. So once you are confirmed about the location of a femoral tunnel, then you drill the femoral tunnel under CM guidance. That's the better thing to do. Once you drill it and take out the bit pin on the another side, then you take a 6 millimeter drill bit and you can drill up to 30 millimeter to reroute the graft within the medial femoral condyle. Then we reroute the graft subcutaneously and then we take it out from the lateral side through the bit pin. So this is the video of graft passage in the femur. You can see that how we have actually taking out the graft from the before taking out the graft, you always remember to put the wear for putting your screws to fix the femur. So this is how the graft is taking out from the another side, and we are ready for fixing it in the femur. So next you fix it with screws. We do it in 30 degree of, and we pull the graft in the opposite side, and 30 degree of knee flexion and neutral rotation. We fix it in the femoral side with screws. So final patellar tracking, we check it after once we have finished both the procedures. Now we check it, the patellar tracking and also the knee range of motion before closing. So this is the patellar tracking. It's absolutely in the trochlear groove. It's not displacing, and fair amount of knee motion is there, and the osteotomy is also properly fixed. There are no movements in the osteotomy site is also there. So even if you push it laterally, it's not going out. So that you are quite confident enough that it's going to solve the problem. So finally, both the videos together, the pre-op arthroscopy and post-op arthroscopy. Pre-op is on the left side and post-op is on the right side. In the pre-op, you can see patella was way above. It was sitting on the lateral femoral condyle. Now on the right side, you can see how the patella is more towards the medial side rather on the lateral side. And it's actually sitting on the trochlea in your knee flexion and extension. So you should be confident enough, fair enough that you have not over tightened it, and also that it's not going to dislocate anymore. This is the immediate post-op. After 3 weeks, the patient has started knee bending forwards. Now the patient has already crossed 3 months and it has already achieved the almost full range of motion, 0 to 130 degree. I don't have those clinical pictures, but these are the 3 months post-op x-rays the patient has sent to me. This is a standing x-ray. The osteotomy site is healing properly, and we can see that patellar holes are quite visible nicely, and there is no iatrogenic patellar injury. The patient is having no pain also. So this was the procedure we have done. So at 3 months, there was 0 to 130 degree painless motion, and there is no episodes of dislocation, and the fear of getting dislocated has also went away from patient's mind. I thank.
I have a question, Arnab.
Yes, sir.
When you need a tracheoplasty?
Trochleoplasty, yes, sir.
Yeah.
So those are the cases in skeletally mature patients. If you see that the trochlear groove is shallow, so we need to do the skyline view to look for the shallowness of the trochlea, and you need to compare it from the opposite side. And also the angulation you can measure from the CT scan. 3D CT can also guide you to look for the shallow trochlea. So in that case, if the trochlear angle is shallow and there is no other associated deformity, especially like the patella alta or patella baja, and there is no varus valgus deformity. In those cases, trochleoplasty to deepening the trochlear groove will be the solution.
Another question is that in recurrent dislocation of patella, as we learned in our days, there were some lateral structures which were more, we have to cut those lateral structures to release the patella. So nowadays, in your series, at least I have not seen that. You have just repaired the medial side. So do you think the lateral release is also important in certain some type of recurrent dislocation of patella?
Yes, sir. I think what we always check for any lateral tight structures, and we always do lateral release before any medial strengthness in cases of habitual dislocation patella. Because in cases of habitual dislocation patella, first we need to release the lateral side, then we need to strengthen or encourage, put any encourage, may it be a pes-plasty, may it be a MPFL, may it be a capsulorrhaphy on the medial side. But in recurrent dislocation of patella, we don't always do lateral release, but we always check for any lateral tight cord is there, or if the ITB is contracted, iliotibial band or something, then definitely we release it. And nowadays we also check for arthroscopically, and we can release arthroscopically also from the inside the joint. So in some selected cases we do that.
I think for habitual lateral release is must, because the pathology is different. You will get a thick cord in habitual dislocation. Recurrent dislocation, most of the time the lateral structures are normal, it's lax. So with
actually,
medial plication,
it is very difficult to identify also, or differentiate also.
It's easy to in pediatric patients, but in adult patients with a big muscle around, it's very tough. Very tough.
So do you suggest that arthroscopically some release of lateral structures will hamper something?
No, it will not hamper, sir. But if the lateral tightness is there, and
it is very difficult to understand the lateral structures are tight or not during your. So if I suggest like this, you do the medial side, but arthroscopically, if you can release certain structures laterally, you will be more confident to realign the patella. That's my way of thinking.
Yes,
whether whether the other faculty agrees or not. I think in recurrent dislocation of patella also there are certain contracture structures on the lateral side which has to be released. So to realign the patella, you just release slightly arthroscopically from the lateral side. I don't see much release which we used to do by open release laterally. Just release arthroscopically something so that you can realign the patella more. Otherwise, probably you have to shift the tibial tubercle more medially than what you are doing after release of the lateral. That's my perception.
It's always option, yes, sir.
Yes, it's always option. And at the end of the procedure, if you feel that slightly still the blood patella is not properly sitting, we can go from the inside the joint and we can release on the lateral side.
The good thing is that with radio frequency, you can just avoid damaging these lateral radicular vessels also, because when you are doing an open release, sometimes post-operatively the patient has huge hemarthrosis because of the lateral radicular vessels also. So I think that radio frequency device, you can avoid this also. Chandanda, any opinion on this?
Am I audible?
Yes, you are audible.
Or no? There are 2 points. How do you identify? Do you go for the isometric point? Number one. Second, how do you assess the tension of your reconstructed MPFL? How much tension you put in? Otherwise, if you do not have that control, you will unnecessarily tilt the patella, and that will add on to your insult to your.
Yes, sir. So the isometric point you were talking on the femur, sir?
Yes.
Yeah, so there is a Scottle's method available that is very popular, and we all follow that. That in the C-arm, you need to look for the exact lateral view of the femur, distal femur. Then you draw a line from the posterior cortex of the femur. And on that line, you need to draw 2 perpendicular lines, exactly 90 degrees. One at the end of the metaphyseal bone of the femur, and one from the end of the that line, what is called 2 lines perpendicular you need to draw, and that point you need to identify, and that is the corroborates with the 90% time that corroborates with the isometric point of the femur. So that point you can one point is the end of the metaphyseal area, and another point is the end of the Blumensatz's line.
Yes,
So two line you need to that.
metaphyseal.
Yes, so that point is corroborate to the isometric point of the femur. So that is quite easy. Now regarding the tension, yes, we surgeons feel that we should tighten. There is a tendency to over tighten. What I have done, and we have seen that when our seniors are also doing any other operations, strengthening operations like fascioplasty and other tightening operations, is also that we pull the graft MPFL from the lateral side. And in 30 degree of knee flexion, we stabilize the patella within the trochlear group and push it slightly on the medial side. It's not that we try to override it on the medial femoral condyle, but just push a slight push on the medial side, so that after tightening, it remains on the more on the medial side, and it neutralizes the lateral pull that was already there. So I can't quantify exactly how pull is there, but somehow we calculate like this intraoperative.
And do you check your isometric point putting your guide wire on flexing the knee and extending knee? Do you
Yes,
check
sir. Ideally it should be done, but to be very honest, we don't check it in every case. But ideally it should be checked after putting the guide wire, then rolling a suture. You should check in flexion and
See the
extension.
movement. If it is moving in transitional side, then I think you should change it. And
yes,
I think there is isometric point for pattern.
I think his connection got disconnected.
He was possibly asking for isometric point for patella.
Yes. So for this case, we have not actually gone for the isometric point of the patella. Rather, we was actually read about the anatomical attachment, what is a fan shaped attachment. So we aim for the superiormost drilling point, keeping a good amount like 2 centimeter of bone in the superior pole of the patella. Then give a 1 to 1.5 centimeter gap, then drill the second one, so that the attachment will mimic like the superior medial portion of the patella, extending from the superior to the half of the medial surface of the patella, to give identical pull like a normal MPF.
Okay. Nice presentation, Arnav. I think we can go. We will head over by last spine case presentation by Dr. Subhadeep Mandal. Rick has also joined. Rick, I can see his name. I can't see Rick. Also, Subhadeep, you start sharing your screen.
Yeah.
Okay. I will call Rick by that time. Welcome, Rakesh.
Rajiv da, is my screen visible?
Yes, visible. You are audible also. Make it full screen.
Okay.
Yeah.
Okay. Good evening, my respected seniors and my colleagues. Myself, Subhadeep Mandal, is working as assistant professor in NRS Medical College, and I also do surgeries frequently in Joint and Bone Care Hospital. I am in debt with Kiran sir and JVC sir for allowing me to blend with the JVCH team. So today I'm going to present one of my case. A 47-year-old male shopkeeper from Purulia came to my OPD in September 2020 with a history of neck pain for 6 months, which was insidious in onset and gradually progressive. There was no history of trauma, but for last 2 months, the pain was rapidly increased in intensity and started radiating along the both upper limb, right more than left, and it was associated with progressive tightness of both upper limbs and lower limb. History of low-grade fever was also there. For last 3 weeks, there was difficulty in standing and progressive weakness of all 4 limbs, and associated with numbness in trunk and below. The patient was non-walker for last 2 weeks. There was no significant contact history, significant past or family history, and there was no bladder symptoms. He was on symptomatic treatment so far. So more or less this patient was presented with neck pain followed by progressive weakness and numbness in both four limbs associated with severe weakness, and patient was non-walker. On clinical examination, his neck movements were painfully restricted. Temperature was slightly increased. He was spastic, and there was hyperesthesia and hyperalgesia along the C5 C6 distribution, but below that there was severe numbness. So more or less this patient was presented with spastic quadriparesis and the level was C5-6. So on history, we had came to know that patient had a history of surgery done elsewhere in 2009 for PIVD at C5 C6 level, for which autogenous bone grafting and C5 C6 anterior cervical discectomy and fusion was done. And after that, in next 10-11 postoperative years, he was more or less good, until unless the symptoms which appeared in last 6 months. And this was the X-ray in 2020. The neutral AP and lateral view X-ray shows the implant, the signs of implant failure was there. There was osteolysis in the fusion mass in C5 C6. The plate, the anterior cervical plate was protruding out of the vertebral column, and in flexion extension view, you can clearly demonstrate that the spine is more or less stiff. The cervical spine is more or less stiff. And associated with this, there is significant degeneration of the cervical column in both AP and lateral view. Coming to the MRI, this is the STIR sequence. You can clearly see that a hyperintense material has been collected in the anterior epidural space. There is significant destruction of the cervical vertebrae in multiple levels, and this hyperintense
Pretty poor connection.
Yes, Subhadeep, you can speak. John.
Oh, and this hyperintense shadow, probably pus or a fluid that is compressing the cervical cord, and there are signs of implant loosening as well. And these features can be clearly seen in both sagittal as well as coronal images. This is the contrast image, which shows there is hyperintensity signal in both in multiple cervical vertebra, collection in the anterior epidural space in both sagittal and axial view. So both the images are corroborative with a spondylodiscitis and collection of abscess in the anterior epidural space, which is compressing the cervical cord, associated with hyperintensity signal in multiple cervical vertebra, which shows the edematous condition of the vertebra and signs of implant failure. This is the CT images, which shows the signs of pseudoarthrosis and the loosened implant, which is gradually protruding out of the cervical vertebra. So with these images, I respectfully ask my seniors what can be done in these cases. In this case, how
Subhadeep, you present your case, then we will have question on this. Yes.
Okay, sir. So after a thorough discussion with patients and his family members, I staged my procedure and planned according to it. On stage 1, I did an implant removal. The implants were grossly infected and loose, and signs of pseudoarthrosis were there. I also did discectomy at C3, 4, 4, 5, and 6, 7, and wedge corpectomy for C4 and C6 vertebra for drainage of the epidural pus. And the entire implant and tissue material were sent for diagnostic workup to detect which type of spondylodiscitis is it, whether it is tubercular or non-tubercular. And for next 2 days, I maintained this patient with Philadelphia collar. In stage 2, I went posterior. I did instrumented fixation from C2 to T1 in best possible lordosis, because because most of the cervical vertebra anteriorly were very soft as mushy, and I don't think it can hold any implant. So therefore, in second stage, I did instrumented fixation from C2 to T1 in best possible lordosis. I did C2, C7 and T1 pedicle screw and rest lateral mass screw, and gradually mobilize this patient from second postoperative day. With the antibiogram report, I kept this patient on intravenous antibiotic for next 3 weeks. The patient started gradually walking with support from the 5th post-op day, and gross power gradually improved to 4 by 5 in both upper limb and lower limbs in next 10 days. And constitutional symptoms were also improved. So these are the reports from Rai Trivedi, which shows the gene expert came out to be negative, and the antibiogram from the screw came out to be E. coli. I also did blood culture report, but surprisingly it came out to be Staphylococcus epidermidis. So coming with the radiological, clinical, intraoperative and these lab reports, I think that this is a case of pyogenic spondylodiscitis due to Staphylococcus epidermidis. I also did urine CS, urine culture sensitivity, but it doesn't show any growth. So in conclusion, this pyogenic spondylodiscitis is an uncommon entity, and cervical pyogenic discitis has an incidence of less than 1% in Asian population. Pyogenic discitis in the presence of an implant producing loosening and pseudoarthrosis is an extremely rare entity. And in our case, the source of bacteremia cannot be traced out even after a heartful searching. So thank you.
Thank you, Subhadeep.
Thank you.
I think now the case is open for discussion. Any question, Kiranda? Unmute yourself, Kiranda.
There is one question.
Yes, sir.
During the primary surgery,
Yes, sir.
What was used for fusion?
Sir, in primary surgery, there was no document, but from the radiology, I think that autogenous bone graft and anterior cervical plate was used.
Actually, the features, this is basically a neck pain was there, but the very rapidly developing signs and symptoms in this
Yes,
case
sir.
within
Yes,
two months, and the amount of bone loss, so in the city, so likely it's to be a case of pyogenic infection. It's not a tubercular infection, but I have encountered through a similar case 2 years ago. It was done outside, and the same type of presentation, the huge amount of pus, huge destruction, but the case was done in a similar way. So there was an anterior plate only,
Yes,
and nothing else inside, and it was written that autogenous bone graft was given. But for fusion, you require a secured fusion. We usually use cage. We usually cage. We use cage, but if you put a G bone or a loose graft,
yes,
so that will lead to pseudoarthrosis usually, and in turn, in future, that may lead to a source of infection there also. So I think the case happened like that. It's usually not a case of tuberculosis.
Yes, sir.
And during the primary surgery, little care was taken for fusion.
Yes, sir. Sir, as this discitis in my as I had received the case, the discitis has involved the C3-4, C4-5, the entire pseudoarthrosis mass, even the C6-7. So either I had to go all anterior, removal of implant, do a corpectomy 3 vertebra, a huge mesh cage and a implant. But what intraoperatively, what I feel that every cervical vertebra was mushy and very much soft. It cannot hold any implant. So I staged my surgery, did a thorough debridement, decompression, the evacuation of pus, cleaning of the anterior epidural space, And after 2 days, I went posterior and did a long fusion.
Even you have done a 3-level corpectomy, you have to put up posterior support also.
Yes, sir. Yes, sir.
It's
I have one question.
Yes, sir.
Yeah, Chandanda.
Subhadeep,
Yes, sir.
because I do not have much of spine experience, so this is sort of my question is, what is the ideal difference between two surgeries? Because you have a frank pyogenic infection.
Yes,
so like 2 weeks is sufficient, or how do you calculate what is your parameter that this is the right time to go in? Number one.
Yes, sir.
Number two, with this amount of bone loss,
Yes, sir.
is only posterior fixation sufficient enough to give stability, or you need a combined anterior posterior fixation?
Yes, sir. So the answer to your first question is that in pyogenic spondylodiscitis, the presentation is very dramatic. There is a collection of anterior epidural pus. The neurodeficit is also very much fast. So better is to go as early as possible in the presence of neurodeficit and instability. If there is no instability or neurodeficit, you can start intravenous antibiotic. Sir, are you there?
Yes, yes, still.
Yeah.
Yes,
Sir,
yes.
in the absence of neurodeficit or frank instability, you can go with intravenous antibiotic according to your antibiogram. But if either deficit or instability is there, we have to address it as fast as possible. And the second part is, and the second answer to your question, that sir, in my case, I had to support the cervical column in expense to the mobility. So I fused the entire cervical column, because from C34 to C67, all the disc space and the anterior bony mass was infected and soft and presence of pseudoarthrosis. So I had to support the column posteriorly, and I expect with antibiotic, when the infection will cleared out, the anterior column will reconstruct on its own, because mostly it is a cancellous a cancellous bone, and the chance of healing potential in a cancellous bone is very much good.
Good.
So I expect good healing in the anterior column when the infection will subside.
I agree with Shubhadeep. If there is a good posterior construct and with control of infection, so there will be a solid anterior reconstruction also.
Thank you, sir.
Nice case presentation, Subhadeep.
Thank you.
Now we have last case presentation from Dr. Rick. Rick is on on-call duty at his COVID hospital. So I will sharing his screen. He will present the case.
I hope I'm audible. I know I'm just.
Yeah, you are audible.
Yeah, okay.
Rick, you are audible.
Okay. So after a very engaging session about arthroplasty, arthroscopy and spine surgery, we finally come back to our very own trauma cases. So what I'll be presenting is, this is an operative management of glenoid and scapular fracture. There was a series of cases, but however, I'm going to be presenting only one. So if you could change the slide.
Yeah, I can.
So this is the case history is basically, it's a 25-year-old male with a high velocity RTA that he suffered. And he presented to us with this following X-ray. So this is the X-ray that we saw, and thankfully he did not have any other chest trauma or any other head injury. So so after the total evaluation, we could proceed for the next investigation. So glenoid fractures, as you know, are very rare. Yeah.
Yeah, from here, yes.
Yeah. So basically, for glenoid fractures, the indication for non-operative treatment in an aeroplane splint, like we saw in the previous picture, is basically if we have a less than 20-degree glenoporal angle, and if in a scapular body fracture and scapular process fracture. If untreated, the glenoid fractures may lead to persistent pain, malunion, early glenohumeral osteoarthritis, and chronic shoulder instability. It is therefore of utmost importance to properly diagnose, analyze, and treat these fractures like any other intra-articular fractures. So we went for a CT scan in this patient. So if you could go to the next slide.
I think we will go first.
Yeah. So
you want to explain this? Yeah.
Yeah. So what we do in what we did in these cases of glenoid fractures and scapular fractures, to decide whether we needed an operative management, we went for lateral border offset. If it was greater than 20 millimeter, we proceeded for a surgery. If the glenopolar angle was greater than 22 degrees and the angulation greater than 45 degrees. So we went for a CT scan with 3D reconstruction. I've omitted all the other images. We've kept the 3D reconstruction here. So the glenopolar angle was 24 degrees and the offset was 21 millimeters. So we used a modified Judet approach because that was a way by which we could access all the fragments of the fracture. So the positioning was prone. So if you could just skip these slides. Yeah.
Yes.
These are the intraoperative pictures. So next slide, please. So after that, after reducing the fragments, we put in two recon plates for the glenoid fragment, which was thankfully extra-articular. And we also put in a curved recon plate for the scapular body fracture. So this was the postoperative X-ray. And we also have a follow-up picture. So the next slide, please. So we basically immobilized the shoulder for 2 weeks. After that, we started guided passive and active range of motion exercises at 3 weeks, strengthening exercises at 6 weeks. And we encountered a superficial infection in this patient, which was cured by antibiotics. So the next slide, please. So this was the picture at 3-month follow-up. So the previous slide. Yeah. So this was the range of motion that he achieved at 3 months follow-up. So the next slide. So in conclusion, actually this was a series of cases. So I had prepared it for the series. So the other I maybe will present later. So it is basically operative treatment for displaced glenoid fractures is a viable option, and lack of such a treatment does not preclude a satisfactory outcome in all displaced fractures. Thank you.
Thank you, Rick. Now the case is open for discussion.
Rajiv Da, this is Sudipto here.
Yes, Sudipto, please.
Yeah. Rick, I have a question.
Yes, sir.
Yeah. Actually, you have allowed movement of shoulder after about 2 to 3 weeks post-op.
Yes, sir.
Yeah. But what is the need for that? If you operated on a extra-articular glenoid fracture, what is the need to avoid range of motion shoulder exercise for 3 weeks?
We actually had fixed it with 3 plates, but we were not really certain of our fixation. So, I mean, we had a good X-ray, but we allowed some time to pass before we allowed the motion. However, the patient regained all the motion that he had lost. So that was nothing to worry about actually.
Yeah.
However, we could have mobilized it earlier, but we chose not to because we were not really sure about the fixation, even though we had a good post-op X-ray.
Yeah, that is okay. But if you are operating on an extra-articular glenoid scapular fracture,
yes, sir.
It is, there must be some reason behind that, because if you are operating on an extra-articular scapular fracture, the need, the motto should be, you should allow early mobilization of the shoulder, because this range of motion can be achieved with conservative treatment also. Because in most of the cases, scapular fractures are treated conservatively, and this range of motion is achieved by this similar range of motion, or even more. The total range of motion is achieved by about 3 months. So if you are operating on an extra-articular scapular fracture, then it is mandatory to allow shoulder mobilization on the next day or at least after 48 hours.
Right.
Yes, agreed. Rick has agreed on that. So here, I think you have allowed the pendulum movement and the passive abduction
Yes, sir.
immediately
Yes,
post
sir.
operative. Yes. Rick.
Yeah, yeah.
Any more question? Yeah. Rakesh da, we want one question from your side.
Not on scapula. I did have a question for Arnab, but that case is gone.
No. You can ask. Yeah. Arnab is there.
Yes,
Unless,
sir.
I can ask after we close this case.
All right. Yeah. Any more question for Rick? Nice case presentation, Rick. And thank you for participating from COVID duty only. Yeah. You are in PP kit. We can see you on PP kit. Yeah. So, yeah, Rakesh, your question, please.
Yeah, Arnab, I
Yes,
loved
sir.
your case.
Thank you.
You know, every time I see this case, it's always been presented differently. You know, we've grown with this instabilities of patellofemoral joints and, you know, subluxations, dislocations, habitual, recurrent. I've never really understood this pathology very well. I don't know how you guys make up these decisions, looking at TTG and, you know, trochlear groove, shallowness and all that. Basically, the shallowness is based on X-rays and what the CTs look like, but they're very misleading. You know, sometimes it's the plane or the X-rays you take, and sometimes it looks shallow. Whereas if you take actually skyline view, the groove looks very nice. So, and I read most of the presentations are very good coming from the French literature, and they actually make a decision based on the amount of subluxation which happens with what degree of flexion when you are bending the knee, and that's the classification they gave. And they give in their books the transfer of tibial tuberosity is a very rare phenomenon. They actually don't do too much, because MPFL, since we have done the way you actually shown, is such a powerful tool that it actually obviates a lot of these tibial tuberosity transfers. We've actually grown with this operation, so we actually use it very frequently. But I would suggest that, you know, try just using MPFL, at least in your government hospital cases. You will see that it is such a powerful operation. It will obviate the need for tibial tuberosity transfers. The second is, during your presentations, you mentioned that you pass it subcutaneously. I was under the feeling that you pass it between the capsule and the actual vastae. You know, that's
exactly, sir. That was I told mistakenly, but actually we passed it through the capsule.
Because I've tried different ways, and I think that's the best plane to go through. It's very difficult to dissect at times, you know, because of the injuries, but that's the plane you need to go. And I think that Chandan was asking about the isometric point. I don't know whether you come across, Arthrex has got a very good jig for this. You know, it's like a ruler where you have a central hole. So there's one posterior line which you can place exactly on the posterior cortex, and the one vertical line which goes on to the Blumenschatz line. So, and just above that is the hole, and the other line is basically where the metaphyseal and cortex are joining on the superior. So those two lines. So it's 2 millimeter below that line, 2 millimeter above your Blumenschatz line, and just above the posterior cortex. And that hole is where you actually drill your bead pin. The only trouble is the hole is straight, and your bead pin actually needs to go anteriorly and upwards. So the direction of the bead pin is different. So sometimes I just take the outer hole and then actually use the bead pin, take out the scale, and then actually use the whole thing. I wanted to ask you, the main question which I wanted to ask you is, you are not using screws to put your graft into the patella. You are actually taking the threads out and tying them up. Do you think that there is not enough strength in that, and sometimes when you move, it can get loose because you're actually titrating your strength on this ligament, and you're allowing immediate movements also after that, based on actually at around 30 degrees, and then actually taking through different modes, and at 30 degrees is where you're tightening this graft. So you think that just the tightening of hand strength may loosen out later on, or you're happy with this so far?
So far we don't found any loosening, but yeah, theoretically the possibility of loosening is always there, and obviously a fixation via implant or anything on the opposite side or a suture anchor would be a better option. But we thought that some healing usually occurs at the graft and bone interface, at the opening at the mouth of the patella. And if you put a good amount of graft, because we put the 2 threads of CEMETI, rather than where the other procedures are there when you use the quads tendon and other things. So actually we are mimicking that it is actually holding the patella in a wider surface of area. So the stress is distributed in both of them. So that makes a concept that the chances of loosening or loosening of the graft might be less compared to when you put a single graft or when you use a solitary graft like a thing.
No, you do put the two arms. One
Yeah,
is
we
exactly,
can put.
Yeah, but it's normally the swivel locks we use to get the graft in.
Yes, yes.
And if you're using only like 20 mm or 27 is what we would recommend normally drilling. It does have the chances. I have actually seen the patella we have in our country is very small.
Yes,
and that
especially
is why
in female patients, sir, it's very difficult.
And that is why my preferred graph is gracilis rather than actually ST also, because that mimics exactly the 4 mm you want to put it in. ST sometimes becomes bigger for these procedures.
Right.
The another, I think, way by you can avoid this bungee effect as the movement of the graft inside the tunnel is just use stitches over the aperture, and that is the way by which you can avoid the lengthening or widening of the patellar tunnel.
As we do in pestplasty, we stitch the soft tissues with the periosteum and surrounding capsules.
That's very important to actually fix, because that also closes your watertight layer also.
Yeah.
Exactly. Sir, I want to add one comment to your thoughts you shared that we should put more stress on MPFL. What we have decided in our medical colleges and other practice that when the patient is having a clear-cut history of injury, that leads to a patellar dislocation. So that is where we are actually focusing more on the MPFL and correcting the medial damage structures. But when there is no clear-cut injury of any injury history of injury, and there are history of 2-3 episodes of patellar dislocations, and a patient have got apprehension test positive, in those cases we actually try to find out there might be some other underlying bony pathologies which actually making the patella more dislocatable, which is actually causing the medial structural injuries. So in those cases we always try to find out the bony pathology and try to always combine the procedures for having a good results.
Yeah, the same what I was saying. If your dislocation starts happening before 30-degree flexion, there's a French classification based on this, and I've actually quite liked it. Then I think there are other procedures required, whether it's a trochleoplasty or the tibial prostension. But if it is happening at 60-70 degrees, MPFL is quite strong enough to actually prevent this subluxation or dislocation.
Yes, sir.
Question. I'd like to know. Thank you all for presenting your cases. Yeah, there is some question.
Yes. May I ask one question to Arnav?
Yes,
sir, please.
Can you hear me?
Yes, sir. Please, sir.
Arnav.
Yes, sir.
Most of the surgeons now avoiding pestplasty. What is the reason? It is a simple operation we used to do and we were successful. Still we are doing. Why you are avoiding this pestplasty?
Sir, we are not avoiding. We are doing lots of pestplasty at SSKM in regular basis. But as we are now becoming scopy surgeons, we try to keep our graft options, intact so that we can use the SEMIT for our ACL later on. Maybe that is the one. But maybe I don't know. But maybe the modern literature or modern textbooks don't re-emphasis on these procedures. But we have did many procedures of pestplasty with very good results. But in pediatric patients, but in adult patients, we doubt that this may give some good results. So in adults, this is not that much strong. What I feel.
Another question. Who will? Yes.
Can I?
Yeah, one more question is from Giri sir, I think. Yeah.
Oh. Yes. Who will take over the function of semitendinosus, particularly flexure power of the players? Who will take the power of the semitendinosus?
The Slocum and I think pestplasty was described for habitual dislocation. For recurrent dislocation, it was never recommended. Even you go to the textbooks for recurrent dislocation, MPFL reconstruction has been the treatment of choice. But yes, for habitual dislocation, we have good result with this Slocum and pestplasty procedure because you are putting it in the lower part, and in the MPFL reconstruction, you have to put the graft in the upper part. And that is the main difference. That is the main difference.
Or no?
Yes, sir.
Yes,
I have one apprehension.
on particularly the semity tendon, it is avascular, and you are using it and getting good result. It is obvious, but my confusion is as it is avascular in the long run, or after 5-6 years, whether they fails or not, whether there is long-term follow-up studies are there or not.
Yes, the long-term follow-up studies are there, not on the procedure I have shown, but there are many other procedures or MPFL reconstruction with SEMIT as a graft, and they have shown us very good long-term results. And what happens, still being it as a avascular graft, but there is some healing happens in the tunnel, orifice of the bone tunnel and the graft interface. That actually gives some fibrous healing, which actually works as an attachment of the ligaments. So that is why it's as Rajput sir has already told, that is why it's better to put a tight some fixation that actually helps in this bone and graft healing, which is not there in my procedure, which I have told, and I am only relying on the suture and the tightness of the knot on the opposite side. So that is the one apprehension. So maybe we need to take a long follow-up to comment on that. But SEMIT grafts give good results in all ligament reconstruction operation. That is why it's the gold standard for ACL reconstruction, PCL reconstruction, and even for MPFL also.
Also, we have a study to show that most of this healing is at aperture, not in the tunnel. If you see the ACL healing, if you see the MPFL healing, it's the aperture healing. And sometimes it's the fibrosis and the techniques substitution, which helps in formation of a band, thick band, which acts like an MPFL. It is never an original MPFL. It acts like an MPFL.
I think it acts like a scaffold.
Scaffold. It's a creeping substitution like that.
Creeping substitution. The same thing happens with ACL also, sir. And that is where the ACL graft is very weak at around 4 to 6 months of life. And that is when people have got pain-free and actually trying to do very naughty things. That is when they re-rupture the grafts, when it's just the weakest.
I think we have a very good presentation from Joint and Bone Care Hospital. Thank you, Jadip and Team JBCH for presenting nice cases. And thanks to all senior for joining here. We will have vote of thanks from our President, Professor Chinmay Desai. Chinmay Desai, please.
Yes, I'm here. So, first of all, thank to the Institute, the JBCH, for presentation of this type of interesting and rare cases, the arthroplasty, arthroscopy, patellar dislocation management, and some trauma, that is the scapular fracture. And also there are lots of experts are there. The experts are there, who commented very nicely. So I think this program is very much helpful to all those listeners and also those who will listen afterwards, because it's the YouTube. Oh, Golokta will. Golokta is there. Thank you.
I'm to say something.
Yes.
Can I conclude?
Yes.
Can I say something?
Yeah. Sure.
Yes, sir. Please, sir.
Rajiv, can I say something?
Please, sir.
Yes, Golokta.
Can you hear me?
Yes, we can hear you.
So, in my opinion, it is an excellent clinical meeting. And really, I have learned something. And as I have seen, a common injury, that is the recurrent dislocation or habitual dislocation, as you tell, it has been discussed most. And it has also helped me at this age when I am a man of 74 years old. And here I can tell you what is in my country, in my opinion, for the children and below the age of 14 or 16, the quadricephaly and release of lateral adhesion or lateral structure should be the procedure. And for the adult, at a time we got the such teaching that we said exercise the patella. But I've learned something new from Ornop's operation. It has given me something. And others are very good. And as regards regarding our prosthesis, the 2 failure cases I have seen. But I have very little knowledge regarding the fracture of the which I've seen in a knee arthroplasty. But as regards hip, I have already commented you. But really, it's really a amazing, interesting, and really a teaching lesson. teaching session. And lastly, I can conclude, I shall congratulate my young generation. They're keeping the height of our WBO flag very high. And last, I shall wish you the coming, best, loving, and enjoyable 2021, other than in this new normal era. Thank you all. Thank you all for
Sir, thank you, sir. Thank you.
Thank you, sir.
Now we will end this session. Arnab, we can stop.
Yes, we can stop.
Thank you.